Thank you, Suzanne. That was very interesting. And leading on from your highlighting the key findings of the report, we'll now move into our panel discussion and Q&A on the issues and challenges ahead for ageing. So to introduce the panel members, we have Stephen Matthews, who is a haemophilia clinical nurse consultant working in the Haemophilia and Thalassemia Centre at Royal Prince Alfred Hospital in Sydney. This unit provides outpatient care predominantly with coordination of products and support to patients when admitted to the hospital due to bleeds or surgery. Frankie Mullen, who works as a senior musculoskeletal physiotherapist at the Alfred Hospital Haemophilia Centre in Melbourne. This is a statewide treatment centre which manages adults who have a bleeding disorder. And Catherine Boddy, who is the Haemophilia and Bleeding Disorders Counsellor from the Australian Capital Territory and region. Suzanne will be facilitating the panel and the discussions, so over to you, Suzanne.
Well, thanks everybody. What I'd like to do now is to follow up on some of the issues that were raised in the Getting Older report, and I guess move it on one step. So we've heard a lot about the great changes in treatment and life expectancy for people with bleeding disorders recently. But I guess this has some implications for haemophilia treatment centres. And what I'd like to do is ask each of you, Steve, Catherine and Frankie, about what you think the challenges are. So I'll start with you individually. I'll start with you, Steve. Recognising, so we do have to understand that all haemophilia treatment centres are different and they do have different levels of resourcing. But from your perspective, what are three key challenges ahead for haemophilia treatment centres?
So, I mean, until we actually face them, it's a bit hard to predict, but I mean, so far, there's sort of some issues around, say, comorbidities. So, for example, heart disease. We're seeing a slight increase at the moment in people having bypass surgery or stenting. And when this happens, we need to put them onto prophylaxis while they're on their antiplatelet medication. And this doesn't just affect severe people with a bleeding disorder. So you might have patients that may have only had one or two treatments in their life before. So how are we going to then manage their therapy while they're on those medications, which can be a bit challenging at times. Another issue that we'll be facing is patients' ability to actually self-treat. If they don't live near a centre, what are they going to do then? So we'll have to sort of manage workarounds for just their prophylaxis. And another potential problem will be if people need to actually go into an aged facility when they can't look after themselves at home. Because as Mike mentioned, some set facilities won't actually provide intravenous therapy. So, I mean, there are new therapies coming out now which are subcutaneous. But again, the problem with those, particularly the Hemlibra, which a lot of members may have changed onto, during clinical trials, the age cutoff was 65. So at the moment, there's not a lot of data on how it can be used in people over 65 with things like heart disease, etc. I mean, there is some data coming out of some European centres that have started to treat their older patients. But until we sort of see that, it's sort of still a new territory as well.
Okay, there's some great points, and I think we're going to follow up on some of them in. I've got a few questions from the audience too, and they're pretty relevant. Okay, so my next person I'd like to ask that to is Catherine. So Catherine, from your point of view, and this might relate to psychosocial workers generally, recognising that all treatment centres are different. From your perspective, what are 3 key challenges ahead?
Well, obviously time factor is a really big deal with haemophilia treatment centres. There's a lot of people to get through in a very short period of time. And I find the deep needs that some people have, particularly around their psychosocial issues, just don't get quite the time frame they need. If they're seen at a 6-monthly or 12-monthly, or sometimes only every second year, if you have a mild haemophilia disorder, you are really not, I guess, getting enough clinical time with the specialists that you need to see, including the psychosocial worker. So I think we probably need to be pretty proactive around whatever timeframes we get to have clients at the hospital, to make sure we see them and look after their needs as thoroughly as we can. So I see that time factor as a big deal. Also, just even having space for a private conversation can be pretty challenging. As we all know, space is expensive in a hospital setting. Fortunately for me, I'm able to see people in the community, but I know that's not actually the case for many of the psychosocial workers. So I'm very advantaged with that. Other issues, I think as people age, the complexity of having dementia issues and general comorbidities that impact the ageing body, who is also affected with a bleeding disorder, are things we don't really know much about yet. And I think just learning to be flexible and expecting change and being prepared, I think, to sort of do as much research as we can for our patients as well, connecting them with other resources, with other people, other disciplines, and in a lot of cases, being prepared to be there to advocate for them. Sometimes they don't have the voice or the words to put out their real needs, so it's really important for psychosocial workers to be flexible and to anticipate a lot of those changes that are going to be coming.
Okay, great. It looks like there's some consistent issues around resourcing, because we're going into new territory. There's so much here that's new, and it's kind of taking us into different directions. So on the one hand, as you say, that there's a whole lot of issues that are new and areas that will need more hours, whatever, to treat. But also, I guess, where you've developed efficiencies and really good tools for having a good consultation or understanding what's going on, now you've got a whole new set of areas where you've got to think through, how do I find out from this person what's going on within the time frame that I've got? You know, I've only got them for a little bit of time, and then working out what kind of environments that you can work in. So this is kind of really different framework, isn't it? Okay, Frankie, over to you. From your perspective, what are 3 key challenges for treatment centres?
Oh, I think the challenge is that we are in a new field of looking after people with haemophilia who are getting older. We were so used to looking after them when they were younger, and now we've got the 2 things we're treating, which is all the pathologies from the haemophilia, but also their ageing. And so there's the arthropathies, the pains, but there's also what comes with ageing, which is the balance, which is often function, like not being able to bend down to even put shoes on, all these little things that go with age, whether you've got haemophilia or not. So we're dealing with both of them. Having said that, I think if we think of the fact that these are people who are, like all of us, aging, they just happen to have haemophilia, you can still, from a physio perspective, get them doing their normal physical activities. And our role is threefold, really. They can come to us when they're starting to have problems, and then not only can we help them with all of these problems that they might be having, but we can also get them going to their local centres, because we're really we can't get them coming into us all the time. Our role really is to allow them to be independent. So their normal community health centres, their normal physios, they can come to us as initial and we can start them on the program. We can communicate with other physios in the community and help them get programs to address whatever issues they might have. And I think for some of the older haemophilia patients, this is a bit of a challenge for them because they're used to being a little bit more dependent on us, the medical side, the hospitals. Whereas as you get older, all of us, it's just maintenance. You've got to just get into a program, and like brushing your teeth, you've just got to do your balance exercises or your keep fit exercises. And I think the haemophilia patient realising that this is part of their challenge as well, and we're there to facilitate that, hopefully.
Okay. Well, I guess that leads on to the next point, which is when you're looking at general health and the kind of issues that are turning up for people with bleeding disorders, I guess a lot of this is going to be managed through their GP. And this came up a lot in the Getting Older report about having a good GP. But so people often need to look for a GP, or they might have had one and moved or whatever. If they don't have a good GP and they're looking for another one, Steve, from your perspective, what makes a good GP from what you need from them?
Well, the most important thing is that the GP is willing to communicate with the centre, because as we know, in the general community, knowledge of bleeding disorders is quite limited. So the chance that you're going to pick up a GP that already has knowledge about bleeding disorders is going to be very unlikely. So maybe a question you can ask is, like, how often would you communicate with my haemophilia treater or the haemophilia centre if there's issues that, you know, may come up, particularly around issues, because GPs will have their own specialists they will refer to. And like in New South Wales, I'm not sure about the other states, but if there's any major procedures that need to be done, New South Wales Health sort of mandates it should be done in a haemophilia centre hospital. So as long as you can sort of make that aware to save you being sort of sent off to one specialist who says, yes, well, I want to operate. And then we turn around and say, well, sorry, no, you can't. It has to be done with us. But I mean, also, I have had some very good regional GPs that contact us when they've got issues and need some advice. And also patients themselves. Sometimes they'll be put on a new medication and they'll say, there's something about if you've got a bleeding disorder or there's increased risk of bleeding, should I still take this one? And we'll look up and say, yes, it's a sort of different problem, so it's still okay, or no, it's not. So I mean, there are a couple of the issues that can really help.
Yeah. So I guess this is an interesting point from the perspective of also around surgery and other medical procedures where there might be complications related to their bleeding. What would you recommend to people? And I guess this came up with their concerns around being able to advocate for themselves. What would you recommend if they're talking to their surgeon and it comes up that they need to have this surgery? What do they need to do in relation to their treatment centre?
Usually they'll give us a call and say, look, I've been told that I possibly will need this sort of surgery. I mean, at the moment with the pandemic, it's been a little bit relaxed. So depending on the type of procedure, we may be able to facilitate it being done more locally for the patient. But anything major would probably still need to see them at the centre. So we will often provide the patient the contact name of the surgeon that works in our hospital and ask if the GP could refer to them instead. And like I said, that just saves a bit of a runaround and delay the procedure's actually happening.
Okay, well, we might come back to this because I think we've got some questions later about how to advocate for yourself when you're not feeling a bit frail and maybe not people aren't listening to you. So, Catherine, I've got a question for you about GPs. So Steve's talked about what a good GP looks like from his perspective. From what you've seen and heard, what do you think makes a good GP, and how do you think that a patient can test this?
I think, again, communication is everything. If your GP is open and willing to learn and prepared to communicate, if they'll accept a call, I think if your haemophilia treatment centre staff member needs to discuss something around treatment, if they'll pick up the phone on that, within time between clients or whatever, if they actually give the respect for the urgency of the call and the need for that immediacy, I think that's really important. I understand, of course, many GPs are really busy and they might get to you at the end of the day, but a lot of our staff, of course, only work till 5 p.m. as well. So I think that's a paramount requirement, establishing a good working relationship that communicates thoroughly and respectfully, immediately as needed. I think that, to test that out with the GP is that they are teachable. It's tough, isn't it, when you feel like they don't want to know much about the bleeding disorder. And I suppose if someone is looking for a new GP and they just don't want to deal with that side of your health, I think you just don't go to them. You ask your colleagues and friends and networks who may already have a bleeding disorder, if they know someone in the area who they're confident with, then maybe that's the person you go and effectively interview and see if you click with them, if they are prepared to take you on. Do the research, really, rather than just, making do, but actually establishing that from the beginning that the communication is good, that you can trust the GP and that they are prepared to learn or are taught already about bleeding disorders. I think that's really important.
Sorry, I didn't unmute myself. Thanks, Catherine. Now, so we've talked about GPs, but what about our community physiotherapists? So, Frankie, what makes for a good community physiotherapist if you have a bleeding disorder?
I think I agree with the fact what Jenny and Catherine were saying. It's a physio that is willing to acknowledge that they may not know it all, that they're happy for us to consult with them, and that the patient feels happy with that physio. And because these patients are getting older and they've had a lot of physio, which I'm sure a lot of them would agree they probably didn't like at some stage, that they're used to seeing physios, and they hopefully have got a physio locally that they have used in the past, and that might be a private or it might be in the community. So as they get older, to keep in contact with those physios or that group of physios would allow a continuation of treatment without reinventing the wheel. So I think there's three things as for a good physio: is the physio in the community is willing to make contact with us at the Haemophilia Centre, or we can contact them, that the patient is very comfortable with them, and that if there are any issues that the patient can contact us back, and we can then contact that physio. And I think the most important thing is, again, that these are to do with people getting older, and you've got to find a physio that is going to treat you as the 60-year-old or 70-year-old, not the 18-year-old. And often it's a bit like going to a GP. It doesn't take long in that first visit to know that that patient just isn't interested in you and is trying to get you to lift weights that really you and I couldn't do, never mind someone who might have joints that aren't all that healthy. So I think it is a matter of, hopefully they'll have someone in their community that they have used. If not, finding someone by speaking around to family, friends, their GP, and if not, just give the haemophilia physio a ring, because sometimes, and we often have done, ring around where that person lives, because people live in Bendigo and Mildura and out in the middle of the outer suburbs, we ring around and find out someone who's listening to us, and then we can refer them to that physio. Yeah.
Okay, great. All right, now I've got some questions without notice from the audience, and bearing in mind we don't have Mike Makris with us, so we don't have a haematologist on board, so I'm going to spring them on Steve. These are, but I thought they were interesting because they relate to some of the issues around, you know, general medicine. So when you're getting older, hypertension becomes an issue. But we've seen that there are higher rates in men with severe haemophilia. And Steve, do you know anything about why that might occur, or is that something that we'll have to refer back to the clinicians?
To be honest, I've really got no idea why that would be the case.
Okay, well, we've seen it, it's in the data. Like the probe data is very obvious, and Mike commented on it too. So, yeah.
So the only thing I could think of is coming back to the increasing in obesity rates, because obesity can increase your chance of hypertension. And depending on what sort of lifestyle you've had with your bleeding disorder, whether that's the main reason associated with it, I'm not sure.
Yeah. Frankie, have you got any comments?
Yeah, it might be the pain factor, because the severe haemophilia, they will tell you they've always got low level pain. And with the new treatment, some of them are amazed how all of a sudden they're not there. We concentrate on their target joints, the pain there, but they all tend to say that they've just got aches and pains nearly everywhere. And we know that pain can increase blood pressure. So that might be another factor.
Mm-hmm. Okay, well, they're really interesting points. And I think, you know, there could be other stuff going on but we're not aware of. But there's another question here which I think is also interesting. I think it's a little too technical for this forum, but what they're asking about the risk of increased osteoporosis with these new treatments. And it says, which are known to increase the risk due to the link with factor VIII and osteogenesis. I think that might be out of our scope. Yep. But Frankie, do you want to comment on osteoporosis generally? Is there anything you've got to say about osteoporosis in older people?
Look, I think we might find that the haemophilia patients just fall into the category of, as you get older, we all get a little bit osteoporotic, and some people more than others. Why that is so, we don't know. And I think you'll find that as a result, it really points to the fact that if that's the case, as you get older, you have to keep up your strength, you have to keep up your activity, because all the research shows that that reduces those osteopenic, those osteoporotic episodes. And if people want to go back and look at the session before this about getting stronger, I think it's really important that these are part of your health routine to stop the osteoporosis. But why more so, I can't answer that. But I think maybe part of the reason is they're just getting older, and it is part of the normal. And then they don't move around as much as, especially when they were younger. And the research shows that a lot of our osteoporotic coverage happens when we're younger. So if you're not very active when you're younger, you haven't got that baseline of good bone health. And a lot of these older haemophilia patients, of course, weren't active because they couldn't be. So it might be more to do with their past history of not being active rather than anything to do with, what they are or are not taking. I don't know.
Can they improve that as they get older?
Yes, yeah. All the research shows that weight-bearing activity, for the majority, there's always outliers, really, really helps that bone. And it's to do with that compression thing. A good example is research shows that those that, not haemophilia patients, but those that play tennis have got much better hips than those that don't. And I think it's because of the compression. They're doing this on the joint, and bone needs compression. Whereas those astronauts that go into space, haven't got the compression, come back and they're osteoporotic.
Oh, how?
So, you know, to actually challenge your bones is part of your healthy bone. Yeah. So
Okay, great.
that exercise is important.
I wonder.
No matter what your age and not what your
That's right.
severity.
And it might just be more noticeable in those that the haemophilia because they have got joints that are compromised anyway.
Yeah. Steve, you've got a comment to make?
Yeah, I was just wondering on that point, if sort of in the future we'll actually see the rate of osteoporosis go down, because what we're seeing at the moment, prophylaxis wasn't available. So they'd have a bleed, they'd be in bed for weeks or months. Whereas now with prophylaxis being available, I wonder if, like in the future, we'll actually see a decrease in osteoporosis in these patients, just because of the fact they can still do more weight-bearing activity and less bleeds, etc., because of prophy.
Yep, I agree.
Well, that'd be good. That'd be good. All right, now another question. Getting back to our earlier question about advocating for yourself. So we've talked about when you're going off to get surgery or you're dealing with your GP, and I guess health professionals in the community maybe not listening to you, and people in the getting older consultation were very concerned about what might happen as they get frailer. Women were saying, look, they don't listen to us already, and as I get frailer, they're going to just dismiss me. And what happens if I have dementia? So I'm wondering what kind of strategies there are for helping you with that. Like what can you put in place to help you as you get older and need some help with self-advocacy? Catherine, do you have any thoughts?
Yes, I do. I think it's really important to identify early an advocate who could come with you to important meetings. For example, if you're going into an aged care facility and you're concerned about how you would be managed with dementia, with your need for prophylaxis and so on, rather than going alone and trying to remember everything, it's really good to have someone who you trust come with you, just like you would with any important meeting, be it with a lawyer or somebody else. These are really important meetings for setting up a safe future. So go armed with questions and, you know, give people a score. If the centre says, oh, no, we don't have a health professional here, you know, I think it's really important to find out, do they have a registered nurse or do they have someone who has experience with venipuncture or is prepared to give a subcutaneous injection, if that's what it comes to, on a regular basis? And if they go, oh, no, we don't do that sort of thing, or do they allow other health practitioners to come in? So the hospital and the home can work in aged care facilities. And is that something that can be negotiated? You know, community nursing, whatever, those realities for the future. So I suppose it's really important to check the facility out for the adherence to someone who has a ongoing need for medical intervention. I mean, it's not just people affected with haemophilia, but even someone with a diabetic issue or any other chronic condition that requires a regular medical intervention. These are things of the future. As people age, it's getting more and more complex. So these are the demands of the future that our patients will bring. And I think advocating early and putting that information out early will obviously educate the health facilities that these are requirements that aren't just as a unusual or one-off, but they will be a future requirement. So I think being very upfront, proactive, take an advocate, go with a list, and be prepared to reject a couple of places if they're not right for you. So I think treating it as a real investigative situation rather than thinking, oh God, here we go, I have to move, but actually trying to do your work early. Just like you choose where you might want to live, you want to make sure that where you live, you're going to live well. So you get that information early.
Yep. Okay, so we've only got about 5 minutes to go, and there are a couple of things that you've raised there that I'd like to follow up. And I guess one is around nursing homes and making sure, as you say, making sure that they can actually do what's required and this kind of workup that you need to do. Steve, from a treatment centre end, what might you do? I think you've commented in the past that very few people, with so few people getting older, this is a new experience for treatment centres too, and that you've needed to learn as you go. What kind of things might you do to smooth the way for someone going into a nursing home?
Well, like I said, there'd have to be inquiries about what treatment would be able to be provided by the actual home. And if they wouldn't do intravenous treatment, is there like a local community nursing service that would be allowed to actually enter the facility to give prophylaxis if needed? Like I said, with some of the new treatments that are coming along, subcutaneous, that may not be such an issue because subcutaneous medications, I think, are given. But there'd also be education of the actual staff. Because as we get older, bruises do pop up, and we'd have to make sure that they don't just discount the bruises, just the, well, we just had an aging bruise, maybe it does need to be investigated further. And if someone is getting more frail, dementia, etc., you may have to start looking at them as you did when they were a toddler and they couldn't tell you, oh, I've got a bleed in my elbow. So then looking at the physical cues of, oh, this person isn't moving quite the same as they were yesterday. Investigate some things like that.
Okay.
Some of the practical issues, I think.
Yeah. Now, we've only got a couple of minutes. I just want to make one more comment before we have to stop. And that is because, you know, I have this background in advanced care planning, so it's a bit of an issue for me. And that is, you know, considering that people might be unable, you know, they get to a stage where they can't speak for themselves, maybe they have dementia. And I'm going to make a plug now. Consider if your next of kin or whatever is not the person who normally comes with you to your appointments, consider appointing them legally, because that is the person you want to be speaking for you when you're in the nursing home. Who do you trust? Who comes with you? Appoint them legally, involve them every time. My experience with my dad, I was his medical power of attorney. Yeah, I went along. I was the one that helped. But with my mum, I wasn't. That was a lot harder. So my experience, and I know Catherine has a lot more to say about that, but we are running out of time. So I want to thank the panel for this discussion and for all of your contributions. It's been terrific. And I want to thank everybody who's been involved in our Getting Older report, because it was such a big enterprise and I really appreciated everything you did. Now I'm handing back to Jenny. Thank you, Jenny.
Thanks, Suzanne, and thank you, Steve, Catherine and Frankie, for your discussions in the panel. We've certainly covered a wide range of issues and raised some interesting points and provided some interesting tips for people. So I hope that this is the end of the session. I hope that everybody's enjoyed it. We've heard Zev's stories, personal experiences for ageing at 70, covered the clinical issues with ageing, revisited the Getting Older study to see how its findings are being delivered, and we finished with the Q&A panel. I'm sure everybody's been able to take something out of this session. I recommend that you head on over to the e-posters and have a look at the poster, and also make use of the Getting Older Hub on the Haemophilia website. It's a really useful resource. Thank you very much, everybody.